Hello, my name is Walid Brinjikji, and today I'm going to be presenting the first part of a multi-part series on the dangerous anastomoses. So just a word on my references. So these are the three references that I used. Neurovascular Anatomy and Interventional Neuroradiology by Dr. Krings, Surgical Neuroangiography by Drs. Lajounias, Berenstein, and Trebrouge, and then the excellent website neuroangio.org from Maxine Shapiro and Eitan Raz and the NYU group. So just a basic introduction. So we know that the external carotid artery and other cervical arteries are closely linked to the ICA and vertebrobasilar system through embryological development. And many anastomotic channels exist between the extracranial arteries and the ICA and vertebrobasilar system, although they're not seen on routine global angiography. And these channels that can open up, these anastomotic channels, they open up under predictable circumstances. And, one of the things that can happen, with these channels is that you can get inadvertent embolization, which can result in a number of major complications, including stroke and cranial nerve palsy. So what are the conditions in which dangerous anastomoses open up? So number one, it's when there's increased pressure on the feeding side of the anastomosis. So supraselective catheterization or distal catheterization or injection in a wedged position can allow for the opening up of these so-called dangerous anastomoses. You have too much pressure and these connections that were always there in the first place, they open up. Another situation in which you can see these anastomoses opening up is when there's increased demand on the receiving side of an anastomosis. So in the setting of arterial occlusion, for example, there's increased demand on the receiving side of the anastomosis, and I'll show you some examples of that as well. And lastly, in the setting of sumping, so when there's a high flow shunt, which is sumping blood to the shunt, you can have opening up of these dangerous anastomoses, and I'll show some examples of that. So what are some tricks to avoid complications in the setting of dangerous anastomoses? Number one, the non-visualized anastomotic arteries are generally around 50 to 80 microns in diameter. So in general, if you're using particles that are greater than 150 microns, you probably are not going to penetrate these non-visualized anastomoses. However, liquid embolic agents, which basically have an infinitesimally small diameter because they're liquid, right, they will penetrate these non-visualized anastomoses. If an anastomosis is a major collateral to the internal carotid artery, embolization should be avoided. And then if it's present but not major, you can mechanically close the collateral prior to embolization, for example, by using a balloon or coils if it's a non-critical artery. And then now just a word on functional neurovascular anatomy. This is a term that you're going to be seeing thrown around a lot in this series of PowerPoint. And this is a concept that was initially described by Professor Lajounias. And essentially, it's this idea that the arterial anatomy of the head and neck can be divided into territories. We have the internal maxillary territory, the linguofacial territory, pharyngo-occipital, thyroidal, cervical, internal carotid, and vertebral. And adjacent territories have these close vascular anastomotic relationships, and this is where you see those vascular collaterals. And this is a protective thing because if one thing occludes, the other, territory will help compensate. But, with the advent of embolization, it could be something that could cause problems as well. The main regions that serve as the major intracranial and extracranial anastomotic pathways are the orbital region, where you have the internal maxillary to ophthalmic to ICA, or linguofacial to ophthalmic to ICA, the petrocavernous region, and the upper cervical region. And these are the three regions that we're going to be discussing in this lecture series. So the first region, part 1, is on the dangerous anastomoses associated with the orbit. So the orbit and the periorbital tissues are richly vascularized. And it's important to point out that the ophthalmic artery is the only peel artery that has consistent dural and extradural supply that you see on every single angiogram that you do. There are other peel arteries that have dural supply, like the PCAs with the arteries of Davidoff and Schechter, and the ACAs can have some Falcine dural supply, but the ophthalmic artery, you see this on every single angiogram. There's consistently dural and extradural supply. So the ophthalmic artery has these rich anastomoses with these dural and extradural arteries, and we are routinely embolizing the arteries that have the anastomoses with the ophthalmic artery. So understanding these various anastomotic patterns is a key to avoiding complications related to extracranial embolization. So just some basic pearls. Number 1, choroidal blush, which is best seen on the lateral angiographic views in the capillary phase, is considered a landmark for the central retinal artery. So whatever you see supplying choroidal blush is also probably supplying the central retinal artery, which is angiographically invisible, but we use the choroidal blush as a surrogate. The major middle meningeal artery and ophthalmic anastomotic channels are located slightly inferior to the sphenoid ridge on lateral angiograms. So based off this, we basically make the assumption that if you're distal to the sphenoid ridge when you're embolizing the middle meningeal artery, for example, you are probably safe and you are probably distal to the location of these anastomotic channels, and the risk of having ischemic complications to the eye are very low. And lastly, the identification of a meningo-ophthalmic artery is a contraindication to embolization of the middle meningeal artery. And this is something that is important to consider in the case of the chronic subdural hematomas that we're embolizing more and more commonly these days. So what are the orbital region anastomoses? So this is basically a chart, and I've shared this before, but we'll just kind of work through this, okay? So we have our internal carotid artery, and then that supplies, the ophthalmic artery. Ophthalmic artery, there's a branch called the lacrimal artery, and this anastomosis with 3 arteries: a recurrent meningeal artery, zygomaticofacial artery, and zygomaticotemporal artery. And then these go to the middle meningeal artery, transverse facial artery, and deep temporal artery, respectively. Another branch of the ophthalmic artery is the lateral palpebral artery, and this has a zygomatic branch, which anastomoses with the facial artery and the superficial temporal artery. Then there's the ethmoidal artery, which has the nasal septal arteries, which anastomose with the sphenopalatine artery and internal maxillary artery. The supraorbital artery has a frontal branch, which anastomoses with the superficial temporal artery. The medial palpebral artery has branches including the angular artery and infraorbital artery, which anastomose with the facial artery and internal maxillary artery. The supratrochlear artery has a frontal branch, and this anastomoses with the superficial temporal artery. The dorsal nasal artery has branches including the angular artery and the lateral nasal artery, which anastomose with the facial artery. So, you can look at this, and, I'm not asking anyone to memorize it, but it's, just a diagram showing all the different connections that exist between the ophthalmic artery and branches of the external carotid artery. And I'm going to show several nice examples that are probably more commonplace in the coming cases, okay? All right, so case 1. A superficial temporal artery to ophthalmic artery collateral in the setting of carotid occlusion. And just a quick word here. Angiograms performed during evaluation of carotid occlusion are excellent for learning all your different ECA to ICA collaterals. So occlusive disease is a really nice, a demonstration of the importance and presence of these collaterals. So here's this case here. So this patient has an occluded right internal carotid artery, and we're doing a left common carotid artery injection here, and you see this superficial temporal artery, which is then anastomosing with the contralateral superficial temporal artery, and then you see this branch here going across midline, and then you see filling of the ophthalmic artery and internal carotid artery. So this is kind of that in zoom. You can see the superficial temporal artery coming down, ophthalmic artery, and then internal carotid artery. So here's STA, supraorbital artery, ophthalmic artery, internal carotid artery. And here's that again, and just kind of like the native images. And then this is actually a nice demonstration on the CTA that the patient had done, and you can actually see that STA to the supraorbital artery going to the orbit and then the ophthalmic artery. So here's another case of superficial temporal artery to ophthalmic artery reconstitution in a patient with bilateral carotid occlusions. So here we can see this is a ECA injection, and on the ECA injection we do get filling of the distal internal carotid artery and the ophthalmic artery, and here you see the superficial temporal artery to the supraorbital artery going to the ophthalmic artery and then the ICA. And then here again, you can see that on the CTA, where you have that STA going to the supraorbital artery along the superior aspect of the orbit, and then the ophthalmic artery. And then here's just the diagrammatic representation there. And just one more word on this diagram right here. If you look at some of the literature in plastic surgery and dermatology, there are several cases of patients going blind after getting injections of various fillers in the supraorbital area, or these eyebrow type fillers. And the reason that these patients are going blind is probably because there's a reflux of this filler material into the supraorbital area, and then they're injecting it under pressure, and it basically goes into the ophthalmic artery and then can cause occlusion of central retinal artery. And there's also reports of patients getting strokes from these kinds of procedures, and this is why, this dangerous anastomosis. Here's a case of a middle meningeal artery to ophthalmic aneurysm endoleak. So this is a patient that had a giant cavernous ICA aneurysm. And this was treated in the days, before flow diversion. The aneurysm was coiled, and then, the ICA was sacrificed as well. The patient had passed the balloon test occlusion, and you can see here this is a right common carotid artery injection, and you actually see filling of the ophthalmic artery here, and then filling of the aneurysm. And basically you see the middle meningeal artery going to the recurrent meningeal artery, to the ophthalmic artery, to the cavernous carotid, or aneurysm. And then this is just an AP view with a more caudal projection. And I will say that a caudal projection is a great way to lay out the entirety of the course of the ophthalmic artery. So here we see the middle meningeal artery, recurrent middle meningeal artery, ophthalmic artery, and then the aneurysm. And this is actually the MRA from the patient, and you can actually see that middle meningeal artery coursing along the sphenoid, then that recurrent meningeal artery. So these collaterals you can actually see on MRA very well if you look closely. And this is coming into the superior orbital fissure because that's where the recurrent meningeal artery lives. So here's a case, and this is one of the things that we have to look out for when we're doing any type of embolization involving the internal maxillary artery or middle meningeal artery. So middle meningeal artery to ophthalmic artery anastomosis with choroid blush. So here we see our injection of our external carotid artery. We see our middle meningeal artery, that recurrent meningeal artery, then the ophthalmic artery, and then the ICA. And then if you just wait a little longer, you see that, here it is on the lateral plane. If you wait a little bit longer, you see that choroid blush. So when we injected the external carotid artery, we saw the choroid blush. You just had to wait a little bit longer than what you would have to wait for when you're injecting the internal carotid artery. But here you see the choroid blush with that recurrent meningeal artery to ophthalmic artery anastomosis. So again, ICA to ophthalmic artery to the lacrimal artery to the recurrent meningeal artery to the middle meningeal artery. Here's a middle meningeal artery to the ophthalmic foramen of Hurdle variant. So here we see bilateral external carotid artery injections, our middle meningeal artery to recurrent meningeal artery to the lacrimal artery, which goes through the foramen of Hurdle and then into the ophthalmic artery. And here it is on the lateral with the MMA, recurrent meningeal artery, lacrimal artery, and then you see the distal ophthalmic artery right there. And this is what the foramen of Hurdle is right here. It's in the back of the orbit, and this is where you get those anastomoses between the middle meningeal artery to the lacrimal artery, which then goes to the recurrent meningeal artery and then ophthalmic artery. So that's the foramen of Hurdle. So again, ICA to ophthalmic artery, lacrimal artery, recurrent meningeal artery, middle meningeal artery, all going through the foramen of Hurdle. Here's a case with a deep temporal artery to ophthalmic artery collateral. It's an epistaxis case in the setting of carotid occlusion. So here you see injection of the internal maxillary artery for this patient with epistaxis. And we see this deep temporal artery right here. And the deep temporal artery ends up anastomosing with the ophthalmic artery through the zygomaticotemporal artery and then lacrimal artery. And you can actually see the choroid blush on this patient right here. So ICA to ophthalmic artery to lacrimal artery to zygomaticotemporal artery to the deep temporal artery. Here's a case, onyx embolization to the ophthalmic artery during CCF embolization. So here's this patient here, right internal carotid artery angiogram, and you basically see the CCF, and you see this recurrent meningeal artery here coming off of the ophthalmic artery. And this patient was embolized at an outside center and then sent to us for further management. But these were images from that embolization that was done elsewhere. And you can see here the microcatheter is in the anterior division of the middle meningeal artery. And on this injection here, we see that recurrent meningeal artery with filling of the fistula. And the patient, this whole area right here, this whole recurrent meningeal artery was then embolized using onyx. And then you can see here that, the recurrent meningeal artery is embolized, it's filled with onyx. But then you see this onyx trail going along the ophthalmic artery and actually into the internal carotid artery. So this was an example of reflux into one of our dangerous anastomoses. And then here in the supracaudal view that we used previously, you can see here the middle meningeal artery to recurrent meningeal artery to ophthalmic artery. And then in this patient here, you see this coil mass. You see the ophthalmic artery, the recurrent meningeal artery, and essentially the onyx that's lining the ophthalmic artery. And needless to say, this patient had lost vision in the right eye as a result of the embolization procedure. So again, here's that diagrammatic representation. So you see the lacrimal artery to recurrent meningeal artery is a very common anastomosis that we need to be extremely careful of in all of our embolizations. Here's a case of orbital infarction syndrome due to embolization in previously non-affected territory. So this is a case of mine where this is the initial injection in this patient that had a carotid occlusion. We only see filling of the external carotid artery branches. Successfully revascularized the patient. However, you can see here that the ophthalmic artery just ends and there was no choroid blush. And I will admit that this was not noticed at the time of the embolization procedure. And then this is the final, common injection. We didn't wait for the intracranial parts to fill here just for this image, but you can see that there's no filling of the ECA distal to the, takeoff of the posterior auricular artery. So there's no filling of the IMAX or STA or anything. And here, this is the post-op CTA. You can see that, we have, fat stranding in the orbit, some proptosis as well. We see that the ophthalmic artery just kind of ends right there. And then on the coronal image here, you can see that there's clot sitting in the external carotid artery proximal to the origin of the internal maxillary artery. So this patient actually had orbital infarction syndrome because we had the embolus go, we were able to revascularize the carotid occlusion, but then there was an embolus in the ophthalmic artery as well as an embolus that ended up in the distal external carotid artery. And you can see here the ophthalmic artery on the left side, which is filling nicely, whereas on the right side we don't see any filling of that occluded ophthalmic artery. So just an example of orbital supply of both the external carotid artery and ophthalmic artery. Case 9, here's a case of IMAX embolization for epistaxis. You can see here injection of the external carotid artery. And then after the embolization, the patient was blind in the right eye and had severe eye pain. So what happened here? So if you look here, we have middle meningeal artery, and then you can see barely the recurrent meningeal artery, and then you actually see the distal ophthalmic artery filling through the recurrent meningeal artery collateral pathway. And the patient actually had the same variant on the contralateral side. So even though we didn't see any choroidal blush in this case, the embolization of the internal maxillary artery, there was some reflux into the MMA, and unfortunately, some of the embolic material ended up, in the distal ophthalmic artery and probably made its way to at least block off the origin of the central retinal artery. So teaching points, orbital vascular anatomy is complex, so study it so you don't get in trouble. Always look for the choroid blush, although it's never 100%, nothing 100%. Always know exactly where the orbit is and where the sphenoid ridge is when performing extracranial embolizations. One of the things that I was taught in fellowship is whenever you're doing an embolization, with onyx or, particles or something, don't use a working projection. Use your standard apian lateral, because that's how we, that's our normal when we're looking at anatomy, right? So where the orbit is every single time on a standard apian lateral. Where the carotid is on every time on a standard apian lateral. But if you do, lots of complex obliquities, it's harder for you to process, where the orbit is, where the ophthalmic artery is, where the ICA is, etc. Thank you very much for listening, and the next part of the lecture series will be on the dangerous anastomoses of the petrocavernous region. Thank you.